So let's move on to the assurance reports now. We've got a series of our board committees, each looking at specific parts of our activities. The first on page number 46 is our Quality and Patient Experience Committee. Unfortunately, Sue Marshall, who's the chair of that committee and would normally present the report, is not able to be here today. But Dr. Raghu Rajan, you're a member of that committee, and so could you maybe make a few brief introductory comments, please, and then we'll go to questions.
Thank you, Chair. Yes, the committee met on the 4th of December and sought assurance from various reports that were presented at that committee, including the dashboard, and on healthcare associated infections and intensive services, safeguarding paediatric audiology. And I'm taking the paper as read, so I'll just highlight some notes that some of the discussions from that committee.
Yeah.
The Quality and Patient Experience Committee discussed the rising levels of infections locally as well as nationally and sought assurance on the actions being taken to reduce level and risk. With high occupancy levels, the increasing risk of infections are a challenge, and providers have plans in place to ensure high standards of cleaning are in place, as well as plans to address and manage microbial stewardship, as well as good hand hygiene. Vaccination rates are improving for all vaccines for the population as well as for staff, and staff vaccination is already higher than last year, this time last year, and it still remains a challenge, but work is ongoing to raise levels even more by using roving vaccinators. There was a David Fuller inquiry on how an individual was able to carry out inappropriate and unlawful actions in a mortuary in Maidstone and Tunbridge Wells NHS Trust and why they remained unnoticed for so long. There are recommendations for all organisations to review around regulations regarding mortuary premises and management of mortuary staff. The Human Tissue Authority inspection is also taking place across all organisations that have a mortuary and are responsible for. East Sussex Healthcare Trust have received theirs already and have had 2 recommendations to take forward. In the Nottingham review into mental health services at Nottingham NHS Foundation Trust, the review identifies areas such as assessments, care planning, communication, where there is learning to be had, and has made 17 recommendations that form part of the staff assessment plan. Progress in relation to the recommendations has already been submitted to NHSC on our part. QPEC will pose in the Quality Patient Experience Committee will receive further assurance going forward. On the business assurance framework, it's agreed from the committee that some training on the business assurance framework will be offered to those members that are outside the NHS who may not be so familiar with the management of the board assurance framework, and the government team have agreed to take this forward. And in other news, the chair, Sue, of Quality Patient Experience Committee and the Chief Nursing Officer visited USSX on the 10th of December and met the Chief Nurse and the non-executive chair of the Quality Committee to discuss the challenges and improvements, and did a walk around maternity talking to patients and staff. Maternity shows significant improvements in terms of environment and quality improvement initiatives. Work on other areas such as medicines management and medical devices were discussed, and challenge and assurance updates were requested at future meetings.
Right, thank you. And just from a translation point of view, UHSX means University Hospital Sussex NHS Foundation Trust, just for the benefit of members of the public and anyone that's watching. Thank you, Raghu. Colleagues, can I just ask a really important area here in terms of quality and patient experience? Any particular questions that any colleagues have got on this particular paper? I've got one while people are thinking, if that's okay, and I think we do need to probably just mention University Hospital Sussex, and I've maybe got I've got 2 questions, maybe one for Alison and then maybe one for Mark around assurance. So this is not the first time that University Hospital Sussex has been featured in the Quality and Patient Experience Committee. It looks to me that there is some progress being made, but I suppose the question to you, Alison, as the Chief Nursing Officer, are the quality improvements going fast enough in that particular provider?
Thank you, Chair. So absolutely, we every Quality and Patient Experience Committee, we have a assurance paper in relation to the progress against all the quality metrics relating to university hospitals. What we can see within those metrics is that there is improvement generally across the board in some of the key quality metrics. I think the question around is it going fast enough, I think is an interesting one. We would always want more, wouldn't we? We would always want the improvement to be quicker than potentially what we are seeing. I think it's important to note from an NHS Sussex perspective, we have a good system whereby we are meeting with that organisation on a monthly basis to look at all the quality metrics, outcomes and safety and patient experience metrics. Alongside that, we do note also that University Hospitals has their single improvement plan.
Yeah.
So we have a meeting this week with University Hospitals to review the progress in relation to those metrics that are aligned to that single improvement plan. So I think following that meeting, I think we'll be able to either give more assurance, or we might feel that they're not making the substantial improvement that we had agreed with them.
Yeah.
So I think it's ongoing focus. We know there is a lot to do in that organisation, but I think from a metric perspective, we can see that there is improvements to where we were this time last year.
Great. Oh, well, thank you for that. And actually, it isn't always just about speed. It's also having resilient changes that then stick, and quality improvements are maintained. That feels really important. But Mark, just bringing you in from a chief executive perspective, obviously, in terms of gaining assurance that the trust is able to provide safe and effective services more broadly. How does this fit into the overall assurance mechanism that we've got ongoing with NHS England and this particular organisation?
Yeah, thank you, Chair. So well, we have regular, as Alison said, in terms of touch points, whether that be quality review meetings on a more frequent basis. So there's a monthly reporting cycle for those. The single improvement plan meeting, which we meet again on a frequent and regular basis, and then of course the overall provider assurance meetings, and the latter two are both attended by NHS England as well. So we have regular discussion dialogue with the organisation and NHS England in that particular space, and NHS England then take that through to their regional support groups, and indeed looking at any other interventions that they can support the organisation with. Those are just a couple, in fact, of the conversations and meetings that we have in trying to enable support for the University Hospital Sussex in their improvement journey. We also have very frequent and regular meetings with regards to urgent and emergency care pathways, and indeed the elective care pathways, specifically with those patients that have been waiting for a period of time for their treatment. Particular focus at the moment. Claudia and I are attending a meeting just after the board today, in respect of patients that have been waiting over and above 65 weeks for their treatment, and the ambition for that number of patients to be 0 by the end of March this year.
Okay, so I hear very clearly there's a lot of contact with University Hospital Sussex. Is that actually leading to genuine improvement, do you think?
Well, I would hope so, very much, in terms of, if I just take the RTT, the elective position or referral to treatment position as an example of that, the support that we've been able to put in place both from a national, regional system and hospital perspective is absolutely there, and will be true in the number of patients we're able to see and treat by the end of this financial year. And that continues. I don't think there's any lack of ambition from the organisation to absolutely improve from the position which they are in at the moment. And we are trying to make sure there's a balance of support, but equally time, sort of freedom, if that makes sense, to make the improvements, as opposed to continuously reporting on this situation.
Okay, thank you for that. Jane, I know you want to come in, and then I'll come to Mark.
So it is not related to that point, so if not,
That's good. Go for it.
No, lovely, thank you. So I'm really pleased to see the Nottingham report in there, as I would from a mental health perspective. But I would ask, request that maybe for future committee business meetings, it's on the agenda to be reviewed, particularly with respect to the cases for change and the move to integrated neighbourhood teams, to ensure that things don't get lost and missed in that. So,
of course, we'll make sure that's on board, Jane. Thank you.
Okay.
It's a really important piece of work, isn't it? It's a really important review, so absolutely.
Yeah, thank you for that, Jane. So Kerry, just for the minutes, if you can just record that actually there's been a recommendation that the Nottingham report is reviewed by the Quality Patient Experience Committee on its forward plan. Okay, thank you for that. Mon, you had a point.
Yes, and as a member of the committee, I was also delighted to have the opportunity to have Martin Llewellyn and obviously also our own James presenting on the research partnership across Sussex, because obviously if we want to improve care, that evidence-based care is absolutely imperative, and so I was really pleased that that conversation came up, and that will go to that board on a regular basis, as will it overlapping with also the audit and people committee. The people and data committee, because actually there's a footprint everywhere for this across the organisation.
Yeah, no, thank you for that. That's a good reminder, actually, because we're planning that actually the Sussex Research Strategy comes to this board, in March is the intention. So, you'll have the opportunity to review that as well. Okay, colleagues, Rahul.
Yes, just on that point that Mon raised, obviously in Mark's report it mentioned about the standing up of the Health Innovation Hub for University of Brighton, and I wonder how that will engage with this body to ensure that we're spending wisely and focused on the areas that can provide maximum benefit for Sussex.
Okay, so James, do you know about the Health Innovation Hub?
Yeah, so what we're trying to do, I think, in response to your question, is build the governance in so that actually we raise the profile of research and innovation and ensure that it aligns to the strategic ambitions for NHS Sussex and improving lives together. So we're well linked in with the Health Innovation, Kent, Surrey and Sussex. I'm one of the SROs for the secure data environment. And so we're really trying to raise that profile, but I think we do need to do a little bit of work about raising the profile to the board level and obviously make sure that we've got really robust governance through the organisation up to board.
Yeah, and I think that might be when this paper comes back to our board next time. It's probably a good opportunity to check that that's the case in terms of that. But there's good working relationships with the Health Innovation Network quite clearly. I think we see that already. In fact, Jane, the chair, and Hatim have attended some of our boards previously. So there's a linkage there, but it's actually what we do with it, I think, is what's really interesting. And so therefore the strategy has to be purposeful, I think. Okay, Raghu.
That was also discussed in the quality committee. One of the suggestions that we thought is that where we identify themes and recurrent things that are problematic within the quality system, whether that is areas of research and innovation that could be taken up by the research and innovation network, etc. So that's how we thought we could link the two together.
I think an interesting topic for the discussion in March will be the difference between research and innovation, because I think the two are separate and we probably need different activities rather than just lumping them all together. It's too convenient, I think. I think Mon would probably agree with that, to make sure that we are really clear. This is research in terms of moving things forward. This is innovation to actually do some sort of internal improvement. So, but we can work through that. Okay, so we're asked to take assurance from this report. Can I just check from the board is content with what we've heard today? Okay, so just for the point of the minutes, the board has taken assurance from the report from the Quality and Patient Experience Committee. We then move on to the Finance and Outcomes Committee. Again, we've been slightly frustrated today because unfortunately Louise Ansari, the chair of that committee, is also unfortunately ill unexpectedly. So I've asked Festina Bayo, you're a member of that particular committee, just to make a few introductory remarks as far as the report's concerned on page 54, and then we'll take questions from there. But Festina.
Thank you, Chair. I will take the paper as read, but I would introduce a few key areas. So the committee met in December where we had detailed discussions and sought assurance on a number of areas. We did receive assurance in areas such as the increased volume in planned care, as well as the reduction in the number of long waiters and the increase in people receiving GP appointments within 2 weeks. We also then noted some areas for escalation, which included 65-week waits, our urgent and emergency care area, cancer diagnosis, as well as our financial position. We probed into all the actions that were being undertaken to understand the drivers and put in place mitigations, where the committee then took assurance of month 7 finance report and the financial position. We also took assurance from the capital forecast report that was presented to the committee. We have requested deep dives in some areas, which include the children and young people mental health, frail falls admissions, as well as planned care for March and June meetings. So I will take it as read, and I'm happy with the help of our executive committees to take some questions.
Okay, Thank you for that, Festina. Okay, colleagues. So there's a lot of content in there, and this obviously overlaps with the integrated performance report as well. So I think in terms of looking at our
Yeah. Also, I just wanted to say that we also had a meeting on Monday to receive a verbal report from our executives on our current position.
Okay. All right, colleagues. Any particular questions that anyone wants to pursue right now? Rahul.
Thank you, Chair, and thank you for the report, Festina. I was drawn to the section on improving data for health inequalities, recognising that there's some work to be done there to improve the confidence in data that's collected across the organisation, and wondered whether there are timescales to actually capture this, and actually where will it be captured in terms of our systems.
We actually had a discussion on how to use more equalities data to improve health equity. With regards to the in terms of the timescales, I'm afraid I haven't sort of got that in.
Okay,
so I would
James, would you be able to answer that?
Again, I probably can't give you the actual timescales, but we can give you the trajectory. So as an action, I'm happy to share the plan with regard to the ask of all of our providers to increase their data recording for health inequality and protected characteristics. We do have a plan, and as I say, happy to share that.
So I think just for the minutes, Kerry, just record an action here for James to provide some information in terms of the timeline for improving the data relating to health inequalities. Okay. While everyone's thinking of other questions, I see in the outcomes requested, there's an action for me, so I thought I'd just ask about that. I've been asked to consider some of the areas of underperformance for the board to review, either in addition to or instead of the committee. So there's obviously 7 or 8 areas here. I just wondered, bearing in mind we have discussed as a board planned care, we have discussed, in last time as well, discharge. I'm just wondering which order we should do some of these other areas in. So what would you say is the next most important area that the board should review?
I think I could take it and then I'll ask it. I think discharge is key for us as a committee, and it's sort of been an ongoing, it's sort of been quite a long ongoing term, so we view discharge as one of the key areas. I think the children and young people access to mental health has also come up a few times, and I think that is another key area that we probably want to explore.
Okay. So other members of that particular committee, were there any other areas that would benefit from a board discussion?
There were 2 areas that we did particular deep dives into at the last outcomes committee. So we did an in-depth review of the cancer programme, and in particular a focus on cancer screening. And we also discussed SMI health checks, so serious mental illness health checks. And we know through the work being done as part of some of the other programmes of work within the system that we have a high prevalence of serious mental illness across the board in Sussex. So it's not kind of, it's when you look across each of our ICTs and the health profiles, it's a fairly consistent high level of prevalence in Sussex. So I wonder whether that's an area in particular that would benefit discussion by the board.
I'm just sort of also wondering, it's really important, I think, we avoid duplication. And if there was good assurance received by the committee on those 2 areas, then it may be less relevant for a board discussion. If there wasn't sufficient assurance received, then maybe we should. But certainly children and young people's access to mental health is not something that I recall this board discussing. And we know there's a perpetuating issue that is maybe worth considering there. Because I've been keen. We don't have a lot of items about children and young people on our agenda, so there's 2 lenses. The impact on children and young people, and then the services that we can provide. But that's much more than just the services that Sussex Partnership Trust provide as well. I think we need to think more broadly than just Sussex Partnership Trust. So what was the review then in terms of cancer and severe mental illness? Was assurance received or not?
Yes, so in terms of the cancer position, we talked about uptake across the various different screening programmes that we see currently within Sussex, and in the main, We do see uptake above the national levels and improving. I think breast was the one area where we weren't above the national average, and we had seen a decline over time. So we did talk in the board about the work that was ongoing, particularly with public health colleagues, to improve awareness in that space. But breast screening was probably the area where we had less assurance because there was a declining pattern in uptake. In terms of the actual performance of delivery of the cancer standards across QVH and ESH, both of those organisations are delivering against 62-day and FDS, the faster diagnosis standard. University Hospital Sussex has been the organisation where we have had challenges, and that is picked up through the Tier 1 assurance process. So I do think it would be duplicative if we were to bring that forward to the board.
But maybe just linking other things together, in James's paper later on cardiovascular outcomes, there's a proposal that we do a similar paper on clinical outcomes for cancer.
Yes.
And maybe actually the breast screening components could maybe fit into that. James, what do you think?
Yeah, absolutely. I mean, if you think about what are the contributors to high mortality rates, there are 3 key domains: cardiovascular disease, respiratory disease, and cancer. And certainly within the CMO directorate, that is something that we would want to be looking at each of those 3 areas with our public health colleagues.
So I think what we might do on the cancer component, let's pick that up in a clinical outcomes paper for this board to review, looking at it from the clinical lens as well. And that feels that would be different to what the Finance Outcomes Committee has already done. What about discharge? Bear in mind we have discussed this as a board. Amy, do you have a view on that?
Chair, I think it might be helpful to bring back to the board, just because I think we discussed the scale of the challenge, but since then we've taken quite a number of actions as a system to rectify our position. So I think it might be helpful to just give an update on our plan and how we're doing against it. For the board, be happy to do that.
And certainly looking at the integrated performance report, we're still 42 out of 42 systems in that domain. So it feels very sensible that we should be looking at our weakest area of performance again for a second time. So I think on that basis we should add to the forward plan discharge, children and young people's access to mental health, and then we'll come on to clinical outcomes for cancer and something around that. Mon, anything else to add?
Just going back to the cancer, just two issues there. Could we have some focus on prostate cancer screening? Because I think there's a huge confusion out there. It's hit the press this week again, and I think people are not very clear on what should be done and the demand from patients on different GPs doing tests. And the second one is related to specialist commissioning and cancer, where that overlaps and fits in. I just would really like to see that given some consideration in that paper and the implications of those changes.
Okay, thank you. That's helpful. Okay, just going back to the Finance Outcomes Committee report, were there any other questions related to the assurance that you've received through that report? I think certainly my issue was discharge, so I think we've covered that. So that was the question that I had. Okay, on that basis, then we're asked to in the agenda to take assurance from this report. Can I assume that we've done that? But I think there's still more work to be done. I think that's the reality. We haven't talked about money, I suppose, is the only other thing. And obviously there's a lot of actions going on there. So just from a committee point of view, Festina, the committee did review the financial position, and we'll continue to do that.
We did review it, and we've had detailed questions and discussions around that. We are assured of the continuous review process and the meetings being held by FOCs and the various trust FOCs. So it's an area that we and that's one of the area we had the verbal discussion on Monday as well.
Yeah, and Hannah, there's a lot of activity going on in terms of trying to manage the financial position. Anything else you want to add to that?
I mean, there is the report. The report says that we were overspent at month 7, and we did put in a financial recovery plan right from month 4, right at the start of the year, because we knew that the plan was stretching. and so that we would need to take recovery actions straight away, and we put financial improvement directors into the system as well. So we've been taking action from early on in the year to mitigate the risks. Of course, new risks have come throughout the year, as they always do, and so we're attempting to manage those as best as we can. So the work continues, is ongoing, and we're in conversations with NHS England as well about the pressures that we're facing.
Good. Okay. I think it would be remiss not to at least mention the money. So I think on that basis, let's take assurance from that report. Thank you very much, Festina, for standing in at short notice as far as that's concerned. And if everyone's content, we'll note that report. Yep. Okay. Noted. So if we then move on to the next committee, that's then People and Digital. And I'm pleased to say we have a committee chair present today. So Rahul Jaitley, we've got a chair of the People and Digital Committee. You can assume the board has read your report. So again, just very similarly brief introductory comments and then we'll take questions.
Thank you, Chair. Yes, and the committee met earlier this month on the 8th of January. And obviously we focused on a number of areas on the people side in terms of including the health and care people plan update, which actually is on the agenda today, so I won't talk about that. But we did look at our workforce equality standards report, and quite promisingly, we've made improvements both on the race and the disability side of things, so that was good to see. In terms of our commissioning for improving lives together, we had a good conversation about the focus of the effort, recognising the resources we have available to support the programme, and supported the prioritisation of the efforts across the 4 main streams. On the digital and data side, we actually received a very comprehensive view of the overarching foundation architecture for digital across the Sussex footprint, which was really good to see. And actually, as part of that, enables us to structure how we will focus on elements of that moving forward over this year. We did do a deep dive in 2 particular areas, so the NHS app and my health and care record, and the Plexus solution as well, and supported the approach to continue rolling those out and getting more traction with the population as necessary. And the last bit I'd like to raise is that we asked the committee to try and put together a list of successes within digital. And we're pleased to see some elements that you probably don't tend to see, which are infrastructure improvements. And actually, this floor is an example of the improvements that we've seen. There might be some issues and challenges, but it's here and exists. But we also the Plexus record as a solution that has been developed within NHS Sussex has been rolled out, and actually that's proving to be very useful in terms of the transfer of care hubs, data, as well as other areas that it's focused on.
Okay, well, thank you very much. I think, again, a comprehensive report, so thank you, Rahul. Very much appreciated. Colleagues, any particular questions? Festina.
Thank you, Rahul, and it's really good to see how we are sort of moving towards digital and AI in healthcare delivery. My question is sort of around how do we ensure that a move towards digital and AI, which is great, does not disadvantage patients lacking, digital literacy or access to technology or internet connectivity in rural areas, as such?
Yes, so as part of that, there is a digital people committee that's established that engages with the population to ensure that any changes that are made in terms of systems and access are scrutinised by that panel to ensure that actually once it's rolled out, it's being effectively used by those with differing digital capabilities. Obviously, there is a challenge, though, in terms of having a solution that works for everyone, but at least that panel is there to have that conversation.
That
to
panel
ensure.
is the one that will continue to seek out oversight and assurance.
Exactly.
Okay, Alison.
Yeah, thank you. And probably just to build on just what's been said, just around our NHS change engagement events that are happening across the system, Festina, one of the questions that we're asking the public is what do they see as the positive benefits of digital and AI, but also what are the barriers and their concerns about it. So we're gaining that sort of information from our local people to help obviously feed into the digital people panel, but also to give us some insight as well as what people are saying and feeling about that movement and that left shift.
Yeah, yeah. But both Alice and I were both at one of the public meetings in the series in Brighton on Friday last week. And sitting listening, I think there was a strong element of choice comes through. So people want to be able to choose to use digital technologies where they've got access to it, and they want to be able to choose not to where they haven't got access to it. And it would be wrong to think it's always about older people. Some of our most deprived communities do not have access to smartphones, and so I think we need to put to bed it's only older people who can't access digital. That is just not the case. So I think listening to these meetings have been very useful to understand practically what it means, and so I think obviously that will come back to our board in due course when we're halfway through that series. But I think the engagement team are doing a good job on trying to understand that very point. Okay, Raghu.
Just a question on digital. Actually, I think it's definitely positive. We'll move forward. Does the committee look at anything that around sort of information to patients? So, for example, historically, patients wouldn't have access to their information and therefore didn't have to interpret it themselves. So, with the availability of senior end results or hospital letters, that sometimes can cause anxiety and confusion for patients who don't understand the implications and how that could be interpreted. And then they Google something, for example, and then they get even more in a panic. So, is there any supportive mechanisms where they are now having access to information that they could, understand what some of these terms, often we use terms that are often understandable for the general population? And
I think it's a really important point, and obviously in terms of the NHS app and the My Health and Care Plan as solutions that are being used by the population, it's very easy for some of that terminology not to be understood, and I think we can add that on to the programme of the committee will focus on to see interpretation of results and what's shared. Is that something that is working effectively or not? Leveraging the digital people panel to try and test that hypothesis that actually is easy to understand.
Could I maybe make an alternative suggestion, if I can, Rahul? Because this actually cuts right across patient experience, actually. So I think I think in some ways it's partly about patient experience and it's partly about the technology. Yeah. So could I maybe suggest that we take an action for you and Sue as the chair of Quality and Patient Experience Committee to decide how best to address this issue. Sure. Because on one or two other cross-cutting issues, sometimes we've had joint committees or we've had specific sessions around that. But I think that might be worth just testing, because what we don't want to do is to do this twice, because that's wasting time and resource. But it is a really valid point. Yeah. I think so. So I think if we can just take an action for the two chairs of the Quality and Patient Experience Committee and the People and Digital Committee, just to review how we assess and gain assurance on the impact of the NHS app and My Health and Care records on patients. Yeah, does that seem sensible? Yeah. Good. Okay. Thank you, Alice. Okay, colleagues. Any other questions around People and Digital Committee? I had a couple, if you don't mind. I suppose really just looking for assurance, Rahul, if I can go back to money. Just looking at the realities that we are currently £40 million overspent on pay costs. And I think section 2.1 lists out all the reasons for that, which I think is good. So there's a good understanding of that. I didn't get a sense of whether the committee was assured that there are actions being taken on that are having an impact.
So we did touch on this within the meeting, recognising the fact that the overspend obviously is for substantive staff and also bank staff to a certain extent. So we have minimised agency spend to a certain extent, but the realities of supporting the elective approach, the specialling services require these in place. And I guess the challenge is how do we manage down the overspend, and what are the implications in terms of service performance? And so I think obviously as we get closer to planning for 24, 25, 26, the realities of what can be done to manage that down will have to be explored.
Yeah. And Hannah, do you want to add anything to that?
Yes, and of course, as you said, this is a big factor in the financial position and why we're working on sort of mitigating the costs. It's important to recognise that the Sussex system, we planned for a decrease in headcount this year compared to last year. So, given the stretching financial position, all providers had a reduction in headcount. So we did have a stretching plan to hit. Nevertheless, we are above that plan, and that is adding costs into the system. And I think it is multifaceted about the reasons which are in the report, and as Rahul said, some of it is about driving the elective programme, and then it has elective recovery funding which funds it. So there's some things which have an offset. Some of it is about just particular pressures and the need to have workforce on wards and so on for safety. So there are reasons behind all of it. In terms of what we were doing, which I think is the assurance you're asking about, is that right from the early part of the, probably think month 3, we put in monthly Chief Finance Officer and Chief People Officer meetings with every provider where we talk in detail through the workforce position and be that substantive bank agency. We put in grip and control processes, and so all of our providers did a self-assessment of all grip and control, which is pay and non-pay. But then each month we talk through what's happening on the pay. We are tracking any vacancies that are being advertised, and the analysis is really in depth about the drivers. So there's a lot of work as to what's happening, and therefore what do we do about it. And I have to say that this month, the most recent month, in month 9, we are closer to plan. So it's certainly moving in the right trajectory. Of course, different months have different levels of activity and pressures, but moving in the right direction. But certainly for next year, we think that there are going to be some tougher targets for NHS England on bank and agency staffing. So we'll be looking to comply with those and seeking to reduce workforce.
See, that's really helpful, Hannah. Thank you very much for just the explanation. I think it's not just providing me assurance, I think it hopefully provides the board and the public with assurance that this has been actively managed. But Siobhan, maybe I should just bring you in just from as the NHS Trust partner member. In terms of obviously as a system, we signed up to reducing the headcount across the piece. That has practically not proved to be the case. I just wondered what the perspective of NHS Trusts are when it comes to trying to manage the workforce numbers and therefore the cost.
Yeah, thank you, Chair. I mean, as Hannah said, I think the first thing to do is make sure that we're consistent in our approach to grip and control. So every organisation has a vacancy control panel of some description with either Chief Executive or Executive Director sign off for vacant posts that go out to recruitment. It's not as easy as saying we cannot recruit to any post, because some posts are critical to safe service delivery and responsive care for the population of Sussex. So the first thing is consistency on grip and control, and we've talked about that. As Hannah says, Chief People Officers and Chief Finance Officers have been the guardians of that all the way through the financial year. The second thing to say is to try to match conversations with ICB colleagues about strategic commissioning intent. So we have to make sure that we don't reduce workforce in areas where demand is increasing and where services will be needed for the population. And that takes a little bit of time. So I think what we're experiencing is growth had already existed in organisations, and that's well documented through the pandemic years. Substantive recruitments were made, and it's not as simple as reversing that, because these are people with terms and conditions and fulfilling predominantly patient-facing roles. So I think really the next phase is right-sizing the workforce based on the strategic commissioning intent, the population demographic, the public health need, and the need to build more services as per government policy in the out-of-hospital space in its broadest sense. And what does that look like? So, for example, in my organisation, we've been reporting to Hannah and up to NHS England, we have grown our workforce numbers because we've been commissioned to provide more virtual wards, more urgent community response, more care home matrons. So it's just an example that the overall macro position is not as easy to deliver as one would expect. And I think there needs to be nuance about population need and service need, as well as grip and control about all of the internal housekeeping factors that providers have already got in place. And I think going into next year, as Hannah said and has signalled, that will probably be an even tougher ask. But there's good collaboration, there's good consistency, and there's better grip and control than there was at the start of the financial year.
Great. I think that perspective is just really brings this to life. So in terms of the way this has been dealt with, I think as a board, when we come to look at the 25-26 plan, I think we should be making sure, if there's going to be a reduction in workforce numbers, seeking assurance on the credibility and robustness of those plans, I think will be quite an important thing for us to consider before we sign something off, because we don't want to make the same mistake again, because actually this is giving us a big financial drag as a system. But understanding the complexity of it, as Siobhan quite rightly points out, understanding the grip and control that Hannah's identified as well. Thank you. Okay, thank you for indulging me on that one. So if there are no other questions on the People and Digital Committee report, then we're asked to note this and take assurance from it. So we're content to do that? Yep. Okay, so carriage to the minutes, noted, and we've taken assurance from that report. So this is a report I've been looking forward to for some time now, the next item on the agenda, and that's our Freedom to Speak Up Guardian report on page number 71. Cassandra and Michaela, you might just want to introduce yourselves again to the board. You're very, very welcome at our board today. It's a really important component of ensuring that we've got an organisation where people feel safe and feel able to speak up when they see things that you know they don't understand or need addressing. So, Cassandra, do you want to introduce yourself, and then Michaela, and then just make a few brief comments about the paper?
Thank you, Chair. I'm Cassandra Blowers, and I'm the Freedom to Speak Up Guardian, inward facing for the ICB only. So I think we need to be quite.
Yeah, that's okay.
Excuse me, I'm Michaela Hawkes, Head of Primary Care and Transformation for NHS Sussex. I'm going to be here to talk to you about Section 6, the external facing. We're working very closely with Cassandra.
Right, thank you very much. So Cassandra, any introductory comments you'd like to make?
Yes, if it's okay with you, we'll do this in two halves. I'll talk about inward facing NH Sussex first. I'll take the paper as read, but I'll pull out some of the highlights. So we've done a high impact action. It's been a very busy year, and that has only one area that we're working with Michaela and her team to deliver at pace. What we've also done is a reflection and planning tool, and that was signed off by the execs back in April. And that gave us a really good position of where we were as an ICB to actually think about, are we doing things as we should be? So I think it's really important to say that the Freedom to Speak Up Guardian in an ICB will receive lots of different things compared to maybe a provider. So I've worked very closely with the safeguarding team. We've got processes in place for our staff to go there with Alison's team, and also met around fraud. And we've got processes there as well. So I think predominantly the cases went up quite high last year. As we've mentioned before, it was a very difficult time for staff during the consultation. So a lot of support was given that way with speaking up. So the figures that you actually see in the paper hasn't changed that much since I've written the paper for you. So I think the next steps of what we'd really like to do is do a 2-year plan, but have a deep dive into lots of other data around workforce. So when the staff survey results are released, see what we can do there. We have got training on Thrive, and that is speaking up for all staff. I do go around the directorates and promote that. That there's listening up for managers and leaders as we've moved into pushing for improving lives together. And there's acting up for leaders as the organisation as well. So I think it's creating those psychologically safe spaces in the organisation. So just to close my bit, the key themes that came up were around the staff consultation, around health and well-being and behaviours mainly. So we were able to sort of give feedback, and I was able to work and link in very much with the equality and diversity team, organisational development team and HR. Right. So I'll pass over to Michaela and she'll give you an update on primary care.
Thank you, Cassandra. Thank you, Chair. Where we are at the moment in terms of our position, we are aware that NHS England have given us guidance that we need to ensure by 2026 that our primary care colleagues have access to freedom to speak up pathways and provision. We have had a preliminary conversation with our general practice colleagues, and we know that there is a varied and wide-ranging resource out there at the moment. As a result, we have entered into a two-phase procurement at the moment. The first phase is now coming to completion, which I'm unable to give you the outcome of that at the moment, but I'm very happy to come back with an update at a later time. That will provide a primary care readiness assessment, and then that will inform us for the second phase of the procurement around the capacity and demand that we're likely to need to procure for our primary care providers. Very happy for any questions.
Great. Well, thank you for that. And I think just from a context point of view, going through an organisational change, which we did between the end of 2023 through to October 24, affecting every single member of NHS Sussex, I think freedom to speak up was never, ever more important than during that particular phase. And I would just like to record our thanks, Cassandra, on behalf of the board for what you and the contribution that you made, and with other colleagues too, during that very difficult time for individual staff. But having a safe space to speak was really important. So thank you very much for all that you've done on that. Just a piece of additional context is that our board also has a non-executive director, Freedom to Speak Up champion, and that is Sue Marshall. So Sue's obviously unfortunately not here today, but I did ask her to make some comments, which I'd like to read out if that's okay, just to provide some non-executive assurance of the activities as well. And Sue's comments were: good progress is being made. The FTSU, Freedom to Speak Up is the acronym, lead Cassandra and I meet up regularly. Sue took part in the reflection and planning tool assessments, and going forward we'll need to ensure actions to align new structures and strategic frameworks. So it feels like it's continuing to evolve. There is a need to build psychological safety within the culture of the organisation by ensuring good feedback to staff when concerns are raised on the actions being taken. But overall, she was very happy with the working relationship and the approach that is being taken. So that was Sue's non-executive perspective. So, colleagues, it's important that we hear this. Would there be any particular questions that anyone wants to raise or comments? Rahul.
Thank you, Chair, and thank you for the report. And it's good to see that we're progressing on the primary care support. I noticed in the high impact actions table and in item 5, there's a network of FTSE guardians being set up. But I was drawn to some of the other papers around integrated community teams and what we will do in that situation where we have different entities coming together, and how do we support freedom to speak up within that area, and whether that's something that's on the radar.
Definitely. But we've created a Guardian, local Sussex Guardian, because I think very much with Sussex Community and Sussex Partnership, ESHT as well. So to be clear, authorities don't need one at the moment. That's and we did say, as we go into the integrated care teams, we discussed it. Who do we? What do we do? And so there is a national Freedom to Speak Up Guardians ICB network, and its inaugural meeting was in December, because we realised we're quite different. And I raised this there. I said it's really important, especially with voluntary sectors as well. So the consensus to begin with would be you would raise that with that organisation. So as a guardian, if something comes to me, I can't open up a case, but I can encourage to go to the Guardian at that service, and if there isn't one, to NHS England, because they're not our Guardian. So I would imagine with voluntary care, we would speak to the leadership team there, but it's not concrete, but I have raised it.
Okay. Yeah. Jane.
Thank you for the report. It's really interesting hearing the ICB side of things. One of the things that really struck me is that all of the Freedom to Speak Up seem to be about HR and people issues and not about patient safety. And given the significant changes and the financial thing, I wondered whether we needed to have a bit of a comms or an engagement thing about speaking up in relation to patient safety.
So I didn't mention that, but yes, since I've come back, we have got a comms plan for the whole year, and I'm working with the comms team with that. So that will do case studies and promote speaking up further.
I suppose there was a time and place, just thinking, going through the reorganisation and every single member of staff on consultation. I think actually that was probably not surprising, but I think you raise a good point about making sure we're thinking more broadly around patient safety. Mark?
So, thank you. And just in respect to that, Jane, so as part of the communications in September, I think it was, just trying to relay back, and then of course in our conference in October. So we do have the avenue, of course, Cassandra and our Freedom Speak Up Guardian, but we also have additional avenues such as the Safeguarding Team and Analysis Team who co-present on our webinars and so on and so forth with Cassandra, inclusive of the work that we've done around the Sexual Safety Charter. So I suppose it might not be going to Cassandra because people may have the mindset of it's a people-related HR-based thing, so we go to Cassandra. It's a patient safety thing or a safeguarding issue, we go to the Safeguarding Team. What would be great, actually, and potentially a future piece of work for us to do as we take these reports through our various executive committees and indeed PD and People in the Digital Committee, is to triangulate that information. So we see safeguarding information, sexual safety information, and Freedom Speak Up as a collective.
Jane, you want to come back?
Just come back. I think that's great because I think with the DASH report coming out soon, it's all going to become linked, and we're going to have to have some response to that when it comes out. So I think that's great.
Great. Okay, thank you for that. Festina.
Thank you very much, Cassandra and Michaela. I'm drawn to the food activity and case management. So one of under the closed cases, because one of them was around perceived detrimental treatment for speaking up, where the CPO had written to the person, but up to date, no response has been received. So I'm wondering whether the communication has clearly been received, but were multiple communication methods used to reach this person, and have they been reassured that there'll be no consequences in responding to that? Because I'm worried that they've not responded to something like that, but then it's a closed case.
So what actually happened, that was escalated to HR and the department. I have to protect confidentiality, sorry. And obviously the directorate, where that was a concern. The person resigned, so we emailed, plus we actually also wrote to them and inviting them, and there was a thorough investigation into it that we could give assurance on. My role is impartial. I open up the case and it's down to the areas to investigate that. So there was a thorough investigation, and that was given to the staff member, and it was, I think, followed up as well, and the member of staff did not come back. So there's only so much.
Sure, of course. There's more context to you explaining to me than what I really think.
But I think it just shows the complexity and the sensitivity involved in some of these individual cases. But it's really important that they're addressed without fear, without favour. And I think that's exactly the approach that I'm hearing was taken. So thank you for that. Okay, colleagues, so we're asked to note this report. Certainly I'd be very keen for this to become an annual event, and we'll work out the right timing, but I think it is important that we are hearing, in terms of from our staff and in terms of the process that's adopted to make sure that people feel safe to speak up. Okay, so if everyone's content with that, we'll note the report with thanks. So, Cassandra, Michaela, if you need to leave, you're very welcome to stay until the break, or you're very welcome to leave. It's your decision. Okay, but thank you very much for your report, and thank you for all your work. We really appreciate it. If I can, though, let's move on to the rest of the next item on the agenda. Page number 81, we've got the Remuneration Committee. Just running a little behind time now, so let's see if we can just speed up over the next couple of items. Festina, you've assumed the paper's been read. Any key points you'd like to bring to our attention?
Thank you, Chair. I think it's a straightforward paper, but just to highlight that we met in December following Adam's full-time move to NHS England, where the committee discussed the interim executive appointments, remuneration, and approved them based on the principle of fair compensation and treating those interim positions as equivalent to permanent appointments. We also met in January, where we had an extraordinary meeting to review proposed salaries for 2 agency staff and the interim deputy CPO position on a fixed term contract. We approved the day rates for the interim agency staff members, and we noted and acknowledged the urgent need for agency support, but the committee highlighted the long-term goal for internal staff development for future leadership roles. All our decisions were informed by benchmarking data and the effectiveness of the whole process attributed to the robust succession plan that was presented to us. We made our decisions reflecting a commitment to maintaining leadership continuity. So I'll say, based on the discussions and the decision made, we had carried out our duties as laid out in our terms of reference.
Okay, thank you for that, Faustina. I'd just like to record my thanks for the committee for being flexible. Obviously, we had to respond at very short notice in terms of the interim arrangements for Chief Executive and Chief People Officer, and also for the other interim appointments as well. So just record my thanks to the committee for that. Hopefully that's relatively clear. Is everybody content with that as an assurance report? We obviously can't go into the individual details of the individuals, but that would not be appropriate. But thank you for that. Let's just note the report with our thanks, and then move on to the Executive Committee. Again, Mark, let's just be mindful of time, but any key points you want to raise on page 84 with the Executive Committee report?
Thank you, Chair. So not over and above that, that's in the content. I think the 4 items to which we'd like to bring to the board's attention, we have discussed 3 of them already during the course of our conversation today, which is fantastic and demonstrates how our governance and assurance works in the organisation. Respectively, that of planned care and cancer and diagnostics, with regards to discharge and indeed our financial position. The one that I would just call out is with regards to our complaints, particularly within primary care and our pharmacy, optometry and dentistry area. You'll see from the content of the report what was reported previously, and the board has reduced, our position has reduced significantly from 100 overdue complaints to 39. The service is now being back in-housed. I can't think of a better phraseology, that's bad for a Chief People Officer, but anyway, it's back with NHS Sussex. And from the 6th of January, and it continues to be an area of focus for us because we know no patient should wait or family member should wait for a complaint over those timescales that were originally set to them. The only other element that I would bring that wasn't raised for escalation was with regards to the Sussex Health and Care Partnership Executive. Colleagues will note from the content of the report that the December meeting was the first in its new format of a new co-chair arrangement, which will now be me and Becky Shaw as our Chief Executive of East Sussex County Council for the foreseeable future.
Okay, thank you for that. So this obviously just completes the loop in terms of governance. Can I just check if there are any questions on what Mark has presented? Okay, on that basis, can we take that report as noted and we gained assurance from that? So we're asked to note the issues escalated for attention. We've been discussing some of those today, and be assured of the decisions taken at the Executive Committee. Okay, so noted on that basis. Thank you very much. And then on to page number 90, the Integrated Performance Report. This again is for completeness. There's an interpretation report in this particular pack. In the appendix, we've got the full Integrated Performance Report that includes all of the measures, not just the ones that are behind plan. Claudia, you can assume that the board read this and obviously the appendix too. Are there any additional points that you want to bring to the board's attention at this point in time?
So I think what we've, in terms of the overview, we've tried to give a balance of areas where we have seen improvement as well as some of the areas of challenge. You'll notice that planned care is pulled out in both of those. The reason for that is really that when you look at the overall waiting list of the system, it has improved significantly over time. So if you look back to September 2023, we had a waiting list of about 234,000 patients in Sussex. That has reduced down to about 192,000. So, and that runs counter to the position in many organisations nationally. So while we do continue to have a problem with long waiters within the system, we are making inroads in terms of reducing the overall waiting list, which I think is important. In terms of out-of-hospital services, we haven't really touched on this in any of our other discussions. And virtual wards is an area that we've discussed previously and consistently delivering the occupancy of 80% or above has been a challenge for us within the system, but we have seen a step change in terms of that performance from around about September, October of this year, and really that has been a big part of the winter plan as well, is making good use of that capacity across the system, and we have delivered consistently above the 80% level and often in excess of 90% over the course of the winter. So good improvements. We've touched on vaccinations already, but again we've seen that improvement since the start of the vaccination programme earlier on in the year. So those are just a couple of areas to tease out in terms of we are seeing improvements, as recognising that we still have challenges in a number of areas.
Great. Okay, thank you for that. And actually bear in mind that Siobhan, you're with us again today, so if I could just bring you back in. Virtual wards, obviously, your organisation has played a big role in terms of that. From your perspective, how well has that rollout gone?
It's definitely been a better winter this winter than it was last winter, and I think the proactive nature of the planning in October, November time has helped. The national rollout was ambiguous around virtual wards, and systems decided whether they would have general wards or specific focused wards. We went with focused wards, and we've had more success in filling general wards. So the learning really was it's impossible to predict the number of respiratory patients who will be matched to a respiratory virtual ward. When you have general virtual wards, you can move patients much more seamlessly and in a timely manner, and that was a real key success factor. The third thing I would say is the collaboration between all organisations around why the model has been evaluated, why it works. NHS England South East Region did a massive evaluation, has improved hearts and minds around trusting that very ill patients can be seen in their own home with the right support from a multidisciplinary team. So there's been a couple of success factors that I think have driven to that, but I would say collaboration has been at the core of it from the beginning of the sort of autumn winter period.
Yeah, and of course it's not just Sussex Community Trust as such doing that. Obviously working with East Sussex Healthcare Trust as well. Yeah, and I think actually it is fair to say though that I think a combination of the urgent community response and the virtual wards is definitely helping us through this winter. That seems to be a tangible difference this year, and that's a credit, and I think our thanks go to you and other colleagues in the system that have been working so well together on this, so thank you, Siobhan. So, colleagues, are there any other questions? Caroline?
Yeah, I was really gratified to see the increase in vaccinations. That's really great. I just wondered whether there's any opportunity to understand where those improvements have been made. So we know that the areas of lowest vaccination affect our population's greatest poor health outcomes. And so are we able to break down that information at all to understand?
I'll maybe bring Amy in at this particular point, as a lead on vaccination.
Yeah, so thanks for the question, Caroline. And the short answer is yes. So we tend to have quite granular data for both COVID, flu, and also RSV by different eligible cohorts. And we break that down by place and also primary care network to give us a feel for where we have areas that require further action and focus in terms of improving uptake. This year we observed improvements from last year, specifically around flu. So we've seen a higher uptake for flu specifically. And our public health colleagues work with my team really closely to target our outreach activities. And I know that in Brighton and Hove, for example, the public health team have worked hand in glove with the federation that delivers the outreach work there. And we've done some targeted efforts around our homeless population and also some of our more deprived communities by actually going to them with the vaccine, and that's helped improve uptake. But the breakdown of all of that performance information is shared on a monthly basis in the Sussex Vaccination Board, which has representation from our 3 local authority areas.
Okay.
That's really helpful to know. And what I'd also really like to see is some triangulation with because those areas are the same areas that have low screening uptake, and so it would be really helpful. And I know those boards do explore some of those pieces of information as well.
There's, again, but been a lot of collaboration, I think, is what I'm hearing, and that's what we learned through COVID. So we must remember the important lessons actually. Raghu.
Just an anecdotal point, it's more that I think there's been a lot more vaccine hesitancy this year from the general population. I don't know if that's vaccine fatigue But certainly it's a good testament that the vaccination rates have improved, because that's quite a good thing in terms of actually there's more resistance from the population for vaccination, I think, across the board.
Yeah, and I think we had a slow start as a system as well, but I think we've definitely improved that position during the season. Okay. Festina, will you ask a question?
Yeah, I did, but I didn't know whether the time and so I'll be quick then.
That's okay.
If that's helpful. Okay, thank you very
We've got
much.
the time, don't worry.
Thank you. So my question was, it was around the health inequality duty, where I noticed that the Mental Health Act detention is quite higher for the Black ethnic group. So I have a question in terms of what measures or initiatives are in place to increase or build trust as well as engagement with the mental health services amongst Black communities. It's page 94 from the Health Inequalities Duty.
Yeah, so in terms of James, can you pick that one up?
I'm actually looking at James. I don't know whether James.
I don't mind speaking
Okay.
to it. Is that all right? So we appreciate there is a significant issue in this area. So the first step we're doing is to implement PCRAF, which is the patient. I can't remember what it stands for. That's awful. But it is the patient something ethnicity. Equality race framework. Sorry, I'd have to get the acronym, but it's PCRAF. And the Lade Smith, who's the president of the Royal College of Psychiatrists, is coming to Sussex next month and she's one of the lead authors of PCRAF to launch it for us and to do workshops through the day. So we're at a very early stage of understanding our data, having a framework for understanding it, and then we will be able to launch. But I think it would be something probably in 6 months to a year back to come back and show the impact of that.
Okay.
Patient and carer race
Thank
equality framework.
Thank you.
To do the translation.
Thank you.
Tony.
Sorry.
There are lots of acronyms in the NHS. Don't beat yourself up too much. So, okay, no, thank you for that. Any other questions around the integrated performance report?
I think I just have one, and it was just of real interest, and it was about the community-acquired infections, because I think we tend to focus very much on hospitals, and we've had a lot of the report in the QPEC has been about quick turnover in hospitals, and therefore hand washing, etc. I was fascinated to see, disappointed, but I mean it is a national trend. Do we know anything about this? I see there's going to be more investigations about the levels of community. I just wonder from a community perspective or from...
Okay. Alison, will you be able to help with that?
Yeah, thank you. So again, I think there'll be there'll be multiple reasons. You'll recall from the paper that came to QPEC that we're starting a antimicrobial prescribing board, because we believe a lot of the acquired, particularly C. diff infections in the community, are through antibiotic prescribing. So probably what an action, Monica, would be for us to, when we come back with our next IPC update to QPEC, is we bring some of that into the report and look at it through that community-acquired lens as well.
No, I think that's why it's good having the sight of the whole integrated performance report, because it allows us to identify other issues to raise. So thank you, Mon. That's helpful. I just had one, and if we can go back to elective care, Claudia. So on section 2.4, it's just at the end of that sentence, it's talking about, no, it's not 2.1.3, sorry, about the mismatch with some of the specialities, the mismatch between demand and capacity. And I just wondered what is being done to address that.
Yep, so it is it'll be part of our strategic commissioning approach as we look forward to really, we know that there are some specialties where we're going to continue to have a challenge. So ENT is one that is a particular area of focus for us.
Ear, nose and throat for the uninitiated.
Terrible with that. Yes, ear, nose and throat. So we know that's a particular challenge. There are opportunities both with our NHS providers to look at how we can increase capacity. So for instance, we've got East Sussex Healthcare Trust have an elective care hub coming online later this year, which will specialise in looking at high volume, low complexity type conditions. And there's an opportunity potentially for us to look at increasing our capacity through that facility. But there's also a look at what more we can provide in the community. So when we think about that left shift, are there the lower acuity end of some of those treatments? Is there more that we could be doing through primary care and community services. So for those areas where we know we've got a capacity constraint that we can't currently resolve, it is taking that strategic commissioning view of what is the long-term capacity going to be that we require within the system, and then what are our options to either expand that capacity or look at different service models.
Yeah, that's great, because it's just identifying the issue with one thing, it's what we're doing about it, which is what you've just explained. I think that's, again, very helpful from my perspective. So, colleagues, if there are no other comments, just a couple of things from me, just by way of closing this section. I think as a board we should note the Integrated Performance Report identifies there's 24 performance measures that we measured against nationally. We are within 5% or achieving 16 of those 24. So I think all of our assurance reports are focusing on the 8 where we're struggling. But let's not lose sight of the fact that 16, are on track or ahead of track of where they need to be. And so I think we need a balance in the performance conversation. I just wanted to make that point and note the fact there's a lot of good work going on, as well as some challenges which are clearly being dealt with great seriousness. So the board is asked to note and take assurance on the content of the report and the areas of concern and escalation. So is it safe to say we can do that? We've noted that. And we're also asked to confirm whether we're assured that the actions contained in the escalation reports, and I think some of the explanations that we've received during the meeting as well, are they sufficient to address the issues identified to date? A number of them are work in progress, let's be frank. So, they are not necessarily, it will be automatically finished. But what I sense is there's a very strong commitment to improve our system-wide performance on a number of fronts, and there's a lot of activity to achieve that. Okay, so on that basis, why don't we note that report with thanks. I think also, bearing in mind it's 11:05, why don't we take a short natural break? If you can try and be back in your seats as soon as you can after 11:15, that will be great. Okay, thank you very much, and we'll take a short break.